Glomerulonephritis Fellowship Program. Advanced training in clinical nephrology focused on the management of patients with primary and secondary glomerular diseases. It is structured as 3 modules, 20 credit each. Each module will be delivered over a 16-week period. This glomerular disease fellowship is open to physicians who are completing or having completed general nephrology training. Nephrology fellows, early and mid-career nephrologists are encouraged to apply. The GN student will be actively participating in a busy weekly glomerulonephritis and vasculitis scientific materials through participation in an ongoing program that includes lectures, MCQs, clinical case scenarios, journal clubs, academic webinars. Candidates completing the program will have developed sound principles and sufficient experience to manage all glomerular disorders. All activities and assignments will be monitored in the platform. Weekly qualitative assessment and evaluation will be performed based on engagement and activity in the program. The objectives of this program: we have designed the fellowship to advance the knowledge of trainees in the diagnosis and management of patients with all types of glomerular disease. The program is structured to enable trainees to complement but not substitute the education provided by the certified clinical nephrology training programs. At the end of the program, the participants are expected to submit abstracts to national and international meetings for presentation and to submit a manuscript for publication in a peer-reviewed journal. For registration and more information, visit worldkidneyacademy.org.
Hello everyone, and welcome to our GM webinar today that's focused on IgA nephropathy. We have very interesting progress and almost a paradigm shift in management of IgA nephropathy with the introduction of several interventions and new therapeutics. So today we are going to discuss some of the traditional and novel therapies in IgA nephropathy. And we have our great speaker today, Professor Jonathan Barratt from Leicester University. And we have great panelist, Professor Pierre Ronco, the chief editor of the Kidney International Journal, Professor Mujtaba, Quadri, American board certified both in internal medicine and nephrology, practicing in Pakistan, Professor Urmila Anandh, a great professor from India. Here is our agenda today. So we'll have a brief introduction about the fellowship. Then we'll have 20 minutes talk about the new approaches of IgA nephropathy by Professor Jonathan Barratt. Then we'll have 10 minutes of discussion. Then we'll have an interesting case of IgA nephropathy presented by Dr. Chigan Ersen from South Africa. Then Professor Mujtaba Quadri is going to give us the closing remarks. So again, congrats for all of our fellows who finished their 2024 fellowship, and they are graduating by the end of this year. We have almost 140 fellows from 48 countries who either finished or are going to finish their GN fellowship for the 2024 class by this year. And we are launching the 2025 GN Fellowship starting from January till end of the 2025. And this fellowship is not only based on webinars or seminars, but it's real dialogue, not monologue, and it's real bi-directional education with a lot of critical thinking and appraisal. And we gather panel of GN expertise. It's based on clinical case discussion, MCQs, journal clubs. So it's very interesting scientific and educational materials. And all of the activities are assigned, and the assignments and tasks are recorded in a smart platform, and quantitative and qualitative evaluation of each of the fellows' performance and engagement is very well structured. Here is module 2. So the fellowship, the 2025 fellowship is 1 year long. It's structured as 3 modules, 16 weeks each. Here is the structure, the syllabus for the first module. We are going to give an introduction and explanation of the basic principle of the GN. Then we'll talk about podocytopathy and comorbidopathies. Then there will be a 3 weeks of module exam. 2 is focusing on the secondary GN, and there will be 2 weeks dedicated to the nephropathology. Then there will be, by the end of the module, we'll talk about rare glomerulopathies, and again, there will be also 3 weeks of module exam. This is the syllabus of module 3. We'll talk about challenging cases of glomerulopathies with hereditary nephritis, post-transplant glomerulopathy, thrombotic microangiopathy. Then we'll talk about traditional and novel therapies in GN. For 2024 GN class, they are going to have their grand graduation ceremony in December 20. So please stay tuned to attend this graduation ceremony online. And we open the registration and the application for the 2025 fellowship. And for the early bird, please use this promo code to get 10% discount. Again, all of this knowledge will have no value without putting it in a practice, because the great aim of education is not knowledge by itself, but the action. And now I'm going to stop by here, and I will let Professor Pierre Ronco to introduce Professor Jonathan Barratt.
Thank you very much, Professor El-Husseini. Well, it's a great pleasure to introduce Professor John Barratt, as he's a world leader in the field of IgA nephropathy. Actually, his research has been focusing since many years on the pathophysiology of IgA nephropathy, which remains a major cause of kidney failures throughout the world. So John is the lead of the IgA Nephropathy Rare Disease Group for the UK National Registry of Rare Kidney Diseases, abbreviated RADAR, and is a convener of the International IgA Nephropathy Network. But perhaps even more importantly, he has been involved as a chief investigator for a number of international randomized controlled trials, phase 2 and phase 3, which have changed the way we handle IgA nephropathy for our patients. Last but not least, he's a co-chair of the WKA-GN clinical study group, and he's the IgA nephropathy lead for the KDIGO clinical practice guideline for glomerular disease. Today, he will speak about new treatment advances in IgA nephropathy, and you will see that it's really a paradigm shift in the way we handle the disease. Thank you very much, Professor Barratt, for having accepted our invitation.
Thanks very much, Pierre, and thank you for that very kind introduction. I have to say, I'm just getting my slides up now. I'll just check everyone can see my slides okay.
It's perfect.
So to tell people on the call how quickly things are changing, I had to rewrite my talk because there were 4 publications came out at the ASN last week of clinical trial data. And I mean, as a KI editor, you must be fed up with IgA nephropathy studies coming to you because things are happening so fast. You think you've got it sorted, and then more papers come out. So this talk is probably going to be out of date by the time I've finished it because something else will be published. So just for the fellows on the call who are interested in glomerular disease, it is a very exciting time for everyone. And we are really seeing a true paradigm shift in IgA nephropathy for sure. So here are my disclosures. I'm going to start off with the scale of the problem. And traditionally, we've thought of IgA nephropathy as a relatively benign disease in people of European ancestry. So people in Europe, people in North America. And where we worry about IgA nephropathy is in East and Southeast Asia, where there is lots of data. It's far more common and far more likely to put you on dialysis. And I thought I'd just show you the UK's experience from our rare disease registry. It's the largest rare disease registry in the world, and it contains over 30 different rare diseases and now close to 40,000 patients. And IgA nephropathy is one of those rare diseases. And we report here for the first time data on just over 2,000 adults and 140 children. And so if you look at the outcomes in what we would regard as a traditionally benign end of the spectrum IgA nephropathy population, when you look at RaDaR here in the UK, at 20 years following diagnosis, if you're a child, 50% of those kids have developed kidney failure. And if you're an adult, 3/4 of those adults have developed kidney failure at 20 years. And just remember that these in the adults have been diagnosed usually in their 20s and 30s. So it means they're developing kidney failure in their 40s and 50s. So that's no age, speaking as someone who's in their mid-50s. And when we look here at what we might expect, certainly in the UK population, that upward arrow there is someone in their mid-50s, so my age. And so if you're a child diagnosed with IgA nephropathy in the UK, by the time you're my age, 3/4 of those children have developed kidney failure. If you're diagnosed between the ages of 18 and 40, 2/3 of those adults have developed kidney failure. And if you're diagnosed between the ages of 40 and 50, half of those adults have developed kidney failure. And so that's the scale of the problem in a population that we traditionally thought actually had the benign end of the spectrum. So this is a significant disease causing significant degrees of kidney failure in relatively young people. And this was in the face of what treatment we've had for the best part of 50 years to treat IgA nephropathy. And it clearly wasn't good enough. And what we did here was we simply took the GFR on the day of diagnosis and the age of the patient at that time, and we predicted what was the likelihood of them developing kidney failure in their lifetime based on these different rates of loss of kidney function up on the vertical axis. So from 5 mils per minute per year, all the way down to 0.1 mils per minute per year. And what we can see here, for those people diagnosed between the ages of 18 and 30, taking their GFR on the day of kidney biopsy and their age at kidney biopsy, unless we got their rate of loss of kidney function down to less than 1 mil per minute per year, every year for the rest of their life, 89% plus of those 18 to 30-year-olds will develop kidney failure in their lifetime. And that is the scale of the challenge we face. And that's the same across all age ranges. And this is because patients predominantly present at a young age. And when we as nephrologists get our hands on them, particularly in the UK, they've already developed significant degrees of kidney damage. The average GFR when I see a patient is between 50 and 60 mils per minute, which tells me they've lost at least half their nephrons before I ever get the opportunity to intervene and treat. And that's the same for studies across Europe, across North America, and certainly we have Urmila on the call. The data we have from India is presentation GFR in patients with IgA nephropathy is lower than we see in the UK. So by the time we as nephrologists get our hands on IgA patients, they've already accrued significant damage. We've always known the greater degree of proteinuria, the more rapid the loss of kidney function. But what we showed here in a European cohort is that even low levels of proteinuria are significant. And you can see here that even below 1 gram per 24 hours, or even below half a gram per 24 hours, 1 in 4 of these patients develops kidney failure at 10 years. And so that idea that we've got this 1 gram threshold that we need to use in IgA nephropathy is completely false. It's man-made, and it was right for the time because that was what the data told us. But we now have more extensive data that tells us that even at low levels of proteinuria, there is a significant risk of kidney failure. And there'll be a paper, I'm not sure whether it's out yet, but a paper coming out in NDT looking at the Swedish population, where they're even getting down to the level of microalbuminuria and showing the impact of that on kidney failure risk in an IgA nephropathy population. So these kind of data that we have from the UK are being replicated by studies from China. There's a paper going to come out shortly from a Chinese cohort. I've spoken about the Swedish cohort, and there's data from the US as well. And of course, we've had data from Cecina Alexander's GRACE cohort in India showing even worse outcomes, in fact, in a South Asian population. So if you take anything from this talk, what I want you to think about is when you see that young patient with IgA nephropathy, don't just think what we're going to do over the next 5, 10, 15 years. Think what is their lifetime risk of kidney failure? Because even if you get them to avoid dialysis for 20 years, it still means they're only in their 40s or 50s when they need to see a dialysis machine. And that, I can tell you, will be a disaster for them. When we see that patient with IgA nephropathy, we give them the diagnosis. We need to immediately institute measures that save every single nephron they've got left, because we know the GFR at the time we as nephrologists are able to intervene in our patients, they already have lost significant numbers of nephrons, and they're young, which means that we need to ensure those nephrons survive for the rest of their life. And we're talking here 40 or 50 years usually. So we have a big task on our hands to intervene early and to give the right treatments to preserve nephrons and prevent our patients from developing kidney failure at any point in their lifetime. And so when I think about IgA nephropathy, I think about two processes that are driving nephron loss. There's the IgA nephropathy itself, the formation of immune complexes, their deposition, and glomerular injury. But there's also the fact that actually, just like any other form of kidney disease, there are those CKD processes, the development of glomerular hypertension and hyperfiltration, the impact of proteinuria on the tubular interstitium, the development of systemic hypertension. And as I've just said, in most nephrologist practice, by the time we meet our patients with IgA nephropathy for the first time, they have all of those processes in full swing because their GFRs are already impaired. So we need to think about how we address both of these processes simultaneously if we are going to preserve nephrons. And of course, it would be great if patients presented to us the minute IgA accumulated in their glomeruli, but we know that's just not the case. What is much more common is that presentation with established CKD already, where we do need to think about treating both of these processes simultaneously. And of course, the treatments for reducing IgA immune complex formation are very different to the treatments that treat generic CKD complications. Thankfully, there's been an explosion of activity over the past few years, thanks to many of you, I'm sure, on the call who have been actively involved in recruiting patients with IgA nephropathy to clinical studies. And we're now starting to see the rewards of that in terms of new data coming out at meetings and new drugs being approved. And that's what I'm going to talk about. But I just want to bring you back. When you see that patient with IgA nephropathy sat across view, this is what should go through your mind. I want to prevent kidney failure in the lifetime of my patient. I must accept there are two processes driving nephron loss. There is the IgA nephropathy itself, the formation of immune complexes, the immunological aspect of this disease, and there is the CKD aspect. And I am not going to win if I just choose one of those. I have to treat both. And when we think about IgA nephropathy, traditionally, our CKD side of the brain has been 95% of the things we've thought about with IgA nephropathy, because we've had very little to treat the immunology. We need to elevate that thinking about treating this immune complex mediated disease with immunologically acting treatments. That should be what we think about when we think about treating IgA nephropathy. And of course, we still need to think about treating the CKD due to IgA nephropathy. And on the right-hand side, you can see what we need to achieve for the rest of that patient's life if they're going to avoid dialysis in their lifetime. And that's trying to get the rate of loss of kidney function down to below 1 ml per minute per year on average. And that is an extremely tall order. So let's just say we have a patient in front of us who's got a new diagnosis of IgA nephropathy. What I'm proposing is the way we think about this is the first thing that should come into our mind is not a RAS inhibitor. It is, I need to address the immunology of this disease. I've just seen a kidney biopsy that's lit up with IgA deposits in the glomeruli. I've seen electron microscopy showing big chunks of immune complexes in the mesangium. I need to treat that. I need to treat the immunology of this disease. And so the next thing I need to think is, what can I do to reduce pathogenic IgA? If it was Pierre giving this talk about membranous in someone with a PLA2R receptor antibody, his first thought when he sees that is, I want to give a drug to get rid of that PLA2R antibody that's causing damage. What you should be thinking about in IgA nephropathy is get rid of those pathogenic molecules of IgA, get rid of that immune complex formation, stop them from depositing in the kidneys and causing damage. The next thing I need to think about is how much inflammation and damage is actually happening at the moment, and do I need to treat that immediately? And that's exactly what we think about when we look at an anchor biopsy, a class 3, class 4 lupus biopsy. Yes, we need to target the autoantibody, but we also need to deal with the damage that's happening in the here and now, which is why we give systemic steroids, which is why we might give avacopan, for instance. Deal with the damage in the here and now while we're getting on top of the pathogenic antibody production. We need to think about that in the same way when we think about IgA nephropathy. And then, of course, we need to accept that actually the patients are presented late. There's lots of CKD in that population. We need to manage the blood pressure. We need to manage the glomerular hyperfiltration. We need to address cardiovascular risk. We absolutely need to continue doing that. But that should be something we think of after we've thought about how we treat the disease itself. And of course, we need to be managing this simultaneously. So how can we reduce pathogenic IgA? Well, if we think about how we target pathogenic antibodies, we have depletion strategies and we have modulation strategies. The depleter we would most commonly use would be a CD20 monoclonal antibody like rituximab. We've tried it in IgA nephropathy and it didn't work. It didn't reduce pathogenic IgA, didn't impact on proteinuria, didn't impact on GFR. So does that mean antibody depletion techniques are not appropriate? Well, actually, we've seen some really interesting data at last week's ASN and at the earlier at ERA, suggesting that depleting CD38 positive cells can be beneficial in IgA nephropathy. CD38 is predominantly expressed on antibody secreting plasma cells. And what we have now are 2 early phase studies that have reported data showing that if you target CD38 cells with either felzartamab or mezagitamab, you can reduce pathogenic forms of IgA, you can reduce proteinuria, and you can slow the loss of kidney function. Now, these are early phase studies. We need to wait for phase 3 studies, but these are certainly something that are going to be coming. And actually, in my clinical practice, for those very difficult IgA patients that are running into problems and where I can't get access to any of these new drugs, we have used daratumumab, which is a CD38 depleter that the hematologists use to treat multiple myeloma in those very, very difficult cases, because we do have that drug in the hospital. And we've seen some very interesting and exciting results. So CD38 depletion potentially coming, but we don't have any large studies yet in IgA nephropathy. What we do have is a lot more data on modulating B cells. And the drug we have the most data for is this drug called Nefecon. It's a specific formulation of the steroid budesonide that's designed to deliver the budesonide to the terminal ileum, because the terminal ileum is rich in mucosal IgA-producing plasma cells. And the rationale here is if you reduce the production of IgA within the gut, That reduces the pathogenic IgA in the circulation, reduces immune complex formation, and will ultimately improve kidney outcomes. And indeed, we've had a phase 2 trial, the NEPIGAN trial, and a phase 3 trial, the NEPIGARD trial, that have both shown that if you use this approach, you can significantly reduce proteinuria and you can slow the loss of kidney function. And we also now have biomarker data that confirms that if you give this drug, it does significantly reduce the level of pathogenic IgA in the circulation. It reduces the amount of IgA immune complexes and impacts on a variety of different pathways associated with the production of IgA within the gut. So some really nice data here. And here's the phase 3 trial data showing that if you give a 9-month course of Nefecon, you get stabilization of kidney function when you're on the drug. But when you stop the drug, unfortunately, the proteinuria comes back and the kidney function then starts to decline as it would have done if you hadn't been on the drug. This is not surprising because we didn't think a 9-month treatment course would cure IgA nephropathy, but what it does tell us is that if you're going to use this approach, you're likely going to need to give repeated cycles of treatment or a chronic low-dose maintenance regime. The good news is that this therapy is well tolerated with very few side effects, mostly those related to a little bit of systemic budesonide absorption, all of which are reversible when you stop the drug. And all of which mean that this drug could be given as a repeat cyclical treatment. And indeed, at the ASN last week, we had data presented on the open label extension of the NEPIGARD study, where patients were given a second treatment course. And what we saw was the proteinuric effect of a second course of Nefecon were the same as the first course, and the side effect profile was no different. So we're already seeing, in fact, in countries that have access to this drug, people being given a 9-month course and then being given a second course when the proteinuria starts to come back. There's a lot of interest at the moment about drugs that target BAFF and APRIL signaling, and these are two cytokines that promote B-cell proliferation, survival, and IgA class switch recombination. And they act, as you can see on the screen, through a series of cell surface receptors. We have monoclonal antibodies that can block APRIL signaling. And so we have 2 phase 3 studies currently for APRIL monoclonals, one of which is completely recruited. And actually, there was a press release a week ago showing that they met their primary proteinuria outcome. So this drug is likely to go through the approval process in the United States next year for the treatment of IgA nephropathy. And we've got the phase 2 data already published last year. And then we have zigakibart, or BION 1301, which is currently recruiting its phase 3 population. So 2 drugs targeting APRIL. But then we have 3 drugs that target both BAFF and APRIL. We have atacicept, telitacicept, and povetacicept. All of these are in phase 3. Atacicept is in phase 3 globally. Telitacicept is only being developed in China. And povetacicept has just started recruitment. And at the ASN last week, we presented some long-term data on atacicept going out to 2 years. And what we saw in the phase 2 study was 2 years worth of exposure to atacicept led to a rate of loss of kidney function in a high-risk population of less than 1 ml per minute per year, that holy grail that we're looking for. And so that's really exciting. It is early data. We need to wait for the phase 3s to report, but there is certainly a lot of excitement around B-cell modulation and its potential future role in IgA nephropathy treatment. So how can we target that inflammation that we might see on a biopsy? Well, of course, the drug we would traditionally go to are systemic steroids. We know they're incredibly powerful anti-inflammatory drugs, but they come at a cost. And the largest study we have is a testing study. And what you can see very clearly is proteinuria goes down when you're on the steroids. When you stop the steroids, it's back up to where it would have been over the next 36 months. And so this is not a long-term fix for the disease. It is a short-term anti-inflammatory approach. The challenge here, of course, is it comes with significant risks, both metabolic, infectious, cosmetic risks, neuropsychiatric complications. And it's really not suitable for a drug that we would want to give repeatedly in a patient population. And the bottom line is the patients probably wouldn't take it anyway, even if we were to offer a second course. So I think they are there. They're a necessary evil in terms of a way of managing IgA nephropathy in the short term. But I think as a monotherapy, long term, they really do not have an appropriate place in the management of IgA nephropathy. In terms of managing that inflammation, we now are in the era of complement inhibitors, and we have a whole range of different complement inhibitors that are being looked at in IgA nephropathy. We have drugs targeting the alternative pathway. The most advanced of these is iptacopan, or what used to be called LMP23. We had a New England Journal publication out last week showing the effect of alternative pathway inhibition in the Applause phase 3 trial, showing that if you block the alternative pathway, you can significantly reduce proteinuria. We don't have GFR data yet, but that will be coming over the next 12 to 18 months. This drug is now approved in the United States for the treatment of IgA nephropathy. So we have the first complement inhibitor approved to treat IgA, not approved anywhere else in the world and unlikely to be approved anywhere else in the world for the next 12 to 18 months. We also have other drugs that are targeting complement factor B. We have a currently recruiting phase 3 trial called Imagination, which is looking at an antisense oligonucleotide that targets the production of factor B in the liver. There's some early phase 2 data suggesting this is efficacious, but this is actively recruiting phase 3 at the moment. And then we have another much smaller early phase study, the Arrowhead study, which again is looking at a different antisense oligonucleotide. So lots of focus on the alternative pathway. We have another drug targeting factor D, which is in early phase 2 studies. No data yet on safety or efficacy of this drug. We have a small study looking at blocking C3, again an antisense oligonucleotide. No data yet, likely to be data at some point next year. And then we have drugs targeting C5. We have another antisense oligonucleotide, cemdisiran, which has been shown to reduce proteinuria by blocking production of complement factor 5 in the liver. But this hasn't been taken forward into phase 3 at the moment. We have data on ravulizumab, and more data was presented at the ASN last week, and we now had a simultaneous publication of the phase 2 Sanctuary trial in JASN showing the data that was presented at the ASN, showing that if you block C5, you get a prompt reduction in proteinuria, which is sustained over the course of the trial. There's a phase 3 trial recruiting at the moment, the ICAN trial, and this is going to evaluate ravulizumab in a much larger population over a 2-year treatment period. So here we are. We've got drugs now that really do address the left-hand side that we didn't have previously, and lots more coming. And then how do we think about the CKD aspects? Well, we've always had lifestyle modification and RAS inhibitors, but it's getting even more complicated. We now have the SGLT2 inhibitors. We have the DAPA-CKD and EMPA-KIDNEY trial. Large numbers of IgA patients in those studies showing benefit. We also have endothelin receptor antagonism. So sparsentan, which is a dual endothelin angiotensin receptor antagonist, was evaluated in the PROTECT trial, which is now published, and we have the proteinuria and GFR data. And what this showed is that if you add an endothelin receptor antagonist on top of a renin-angiotensin system blocker, you slow the rate of loss of kidney function and you significantly reduce proteinuria. So here, an added benefit of a dual approach in that treating that generic downstream CKD aspect of the disease. And you can see here the proteinuria in the middle panel, very much larger proteinuria reduction if you add an endothelin receptor antagonist on top of a RAS inhibitor. And this drug is well tolerated. The major adverse event was hypotension. So you do need to be cautious if you're going to use this drug that it might drop the blood pressure a little bit more lower than you might expect. So just warn your patients about that. So we're now building up the right-hand side of the paradigm here, but it doesn't stop there. We now have an endothelin receptor antagonist, which can be added to any renin-angiotensin system inhibitor called atrasentan, and had a New England Journal publication last week reporting the 9-month proteinuria data. showing that if you add atrasentan to any of the RAS inhibitors, you will get much greater reduction in proteinuria, just like we saw with sparsentan. And then this then opens up the opportunity for a single agent endothelin receptor antagonist that you can use in addition or instead of a RAS inhibitor. So we have an ERA here that's coming, but of course we know the world of CKD treatments is advancing even more. And we've now got mineralocorticoid receptor antagonists like finerenone. There's a large trial in general CKD, the FIND CKD trial, which will have a large number of IgA nephropathy patients in it. So we're going to hear about that. Aldosterone synthetase inhibitors, and then the wonder drugs, the GLP-1 receptor agonists that everyone talks about. No data in non-diabetic kidney disease yet, but these are going to be coming. So you can see in a year or so, well, next year, I'm going to have to get a bigger slide because we're going to have even more drugs to add. And of course, we're also looking at combining these. So there are combination studies with endothelin receptor antagonism, RAS inhibitors, SGLT2 inhibitors, and there's a large study in general CKD called the Zenith High Proteinuria, which is looking at another ERA, zibotentan, combined with dapagliflozin on top of a renin-angiotensin system inhibitor. So the management of CKD is evolving as rapidly as the management for IgA nephropathy, and we're going to need to keep pace with both. So this was what it was like for me for most of my career when I went to the drug cupboard to find a drug to treat my patient with IgA nephropathy. There was nothing in it. For those on the call today, this is what it's going to be like over the coming years. You are going to have many, many different drugs to choose from. Drugs that you might want to use in combination, drugs that you may never have used before, an APRIL-BAFF inhibitor or a complement inhibitor. And the challenge that we face going forwards is how are we going to use these most effectively to slow or prevent the loss of kidney function for our patients? So this is where we were when we wrote the 2021 KDIGO guideline for IgA nephropathy, which is only 3 years ago. That's all we had to talk about. This is what we have today in terms of approved therapies in different parts of the world. And I'm likely going to need to add another drug to that before Christmas, because there's going to be another drug, atrasentan, is likely to be approved before Christmas. And then this time next year, I may be adding an APRIL monoclonal antibody to this list as well, with a BAFF-APRIL drug likely coming in the very near future. And then there'll be these other agents that will be coming. So this is where we are moving. And I can't underestimate how quickly things are evolving. And this is going to be something that we are going to need to really think very carefully about in terms of the right drug for the right patient at the right time. Fortunately, we're also getting companies interested in doing studies in transplant recurrence. And that's something I get called about a lot, is I've got a young patient, they're on their first or second kidney, and they've got recurrent disease. What am I going to do? And so in 2025, we are going to see studies starting looking at sparsentan in recurrent IgA, ravulizumab in recurrent IgA, and atacicept in recurrent IgA, one of the BAFF-APRIL inhibitors. So there is a possibility on the horizon that even if you're unlucky enough to get to the point of needing a kidney transplant and you get recurrent disease, we will have treatment options for those patients as well. So I hope I've convinced you the future's exciting, if not a little bewildering, and you're going to need to keep pace with what's coming, because the likelihood is this time next year, it will be a very, very different talk I'll give, because we'll have far more new drugs to play with. So thank you very much for listening, and I'll hand back to the moderator. Thank you.
Thank you very much, John. It was really a great lecture, and well, all these new drugs are important for the future treatment of IgA nephropathy. We have a lot of questions, and particularly from Professor Abdelhamid Ramadan, and he has 2 questions which are very important. I think the first is why rituximab failed in IgA nephropathy, whereas other B-cell targeting drugs or even plasma cells targeting drugs like anti-CD38 seem to be efficient. What is going on? Why is rituximab a failure?
So I think so we know there are niches in the body that are rituximab resistant, and that likely reflects the microenvironment in which the CD20 positive cells are living. And part of that is likely to be the survival factors that are counteracting the impact of CD20 depletion. And those survival factors are likely to be BAFF and APRIL. And so we know outside of IgA nephropathy, there are diseases we think should respond to rituximab that just simply the rituximab cannot deplete the relevant pathogenic cells. And that speaks very clearly to the fact we believe IgA nephropathy is driven through the mucosal immune system rather than antibody secreting cells sat in the bone marrow or central lymphoid sites. And we know where rituximab works well. It works well in diseases which are classically autoimmune in terms of a loss of tolerance with clonal proliferation of autoantibody producing cells. And these cells live in the bone marrow, they live in central lymphoid sites, not in the mucosal immune system. So I think that is the main reason, is that CD20 depletion is just not very good at depleting those cells that are lying within the mucosal immune system.
Okay, they miss the target. They miss the target. And the second question from Professor Abdelhamid Ramadan, I think is very important. Do you have an algorithm to target the right pathological pathway? I mean, from the kidney biopsy or from, why not, a liquid biopsy, how to choose the best treatment? How can we personalize the treatment? We have now a proliferation of drugs, but what should be the hierarchy?
Yep. So we desperately need a PLA2R or an anchor, a double-stranded DNA. At the moment, we have a Gd-IgA1 level, but we have no proof that that reflects disease activity in a particular compartment, and that monitoring that and monitoring its fall translates to clinically good outcomes. So what we are actively doing at the moment, and what all the trials are doing at the moment, is they've generated a massive biorepository of samples. And so there is an extensive effort underway measuring biomarkers in these samples to see whether baseline values of particular biomarkers predict treatment response, which is what we as nephrologists want to know. Because if we can measure them, we can say, okay, if they've got high levels of whatever that happens to be, they're likely to respond to this treatment. And then biomarkers to say whether patients are responding quickly. So we know to stop a drug if it's not working and change to a new drug. We just don't have them, unfortunately, Pierre, at the moment. We are desperately looking for them, and there's a massive effort underway looking at the samples that have been generated from these clinical trials.
Thank you, John. I think my co-moderator would like to ask questions, to pick up questions from the chat. No? Professor El-Husseini, there are two moderators, right?
Right. Professor Anandh, I think he wants to.
Professor Barratt, excellent presentation as always. And I remember almost 5 years back when you had come to India and talked about IgA nephropathy, things have changed. I have only a few questions. Does the complement co-localization in the biopsy make you think of using complement inhibitors in this group of patients? Like you were saying, I wish you had a biomarker. So IgA nephropathy biopsy, some of them have complement localizing with it. So will that make you decide on atacicept or something else like that? I mean, drugs which can be used in complement inhibition. It's just a thought.
Yeah, I mean, I think, Urmila, that's a really good point. I think the challenge is it depends what you're staining for. So if you stain for particular complement fragments like C3d, that could have been deposited 6 months ago. And actually, we don't, what we need to do is we need biomarkers that know that when we took that biopsy, the complement system was active, and therefore giving a drug to target the complement system is the right thing to do now. And of course, in a perfect world, we'd have a urine biomarker that reflected that. But of course, we can't keep putting needles into people's kidneys because they won't be very happy. So what we need is a soluble biomarker. And we're actually doing studies at the moment where we are collecting urine on the day of biopsy, and we are measuring what we see in the urine and relating that to what's happening in the kidney tissue. So in a perfect world, I'd love to be able to come back and say, okay, if you measure these 3 biomarkers in the urine, that tells you complement is actually being active at the time. and therefore you're likely to get benefit from a complement inhibitor. Because don't forget, for the iptacopan, you can't give it until you've immunized against Neisseria, Haemophilus, and strep.
Yes,
And,
yes, that's true. Sorry.
and these drugs are not cheap. And so
True.
I think we need a good reason to use a drug. I would like to think that if we had those biomarkers, I would make a diagnosis of IgA nephropathy. I would put them on a therapy to target pathogenic IgA production. And then I would make a decision as to whether they needed additional anti-inflammatory support. And if they did, I would perhaps give a complement inhibitor for 6 to 8 weeks, monitor something in the urine to show I'd suppressed inflammation, and then withdraw it, and then come back in with the complement inhibitor if I had to treat flares of inflammation. That's the perfect scenario, but we're a long way from that yet because we just simply don't have the biomarkers.
Professor Husseini, can I ask him another question?
Absolutely, go ahead, please.
Yeah. Professor Barratt, is the combination of RAS, SGLT2, ERA, the dual sentence, get the GFR to less than 1 ml per minute per year decline?
It will
Can
never
just
do.
concept
It won't do that. The worry for me is if you lose lots of hemodynamically acting drugs, you've lost your best biomarker of glomerular health. So I can make myself feel a lot better by dropping the proteinuria with a load of hemodynamically active drugs. It's done nothing to the fundamental process that meant the nephrons were being lost in the first place. And if that means I then don't use treatments that target the IgA nephropathy, I don't think I've done my patient any favors. So I think we just need to be cautious. And this is where new biomarkers are really essential. All the data I've shown you from the registry from the UK and all the data globally, they're all on RAS inhibitors. They're all on heme, and they still progress. You look at the data for SGLT2 inhibitors and endothelin receptor antagonists, the patients are still progressing. Yes, more slowly, but they're still progressing. The first time we've ever seen a really eye-opening, potentially disease-modifying effect is the 2-year data with atacicept, where you are getting down to physiological aging of the kidneys. CKD treatments cannot achieve that because they do not address the underlying disease problem.
Thank you, Professor Husseini. Thank you, Professor Barratt. Thank you very much.
Thank you so much for this very nice discussion. Again, when it comes to the developing countries, maybe the picture is a little bit different. And also when it comes to children with IgA nephropathy, these medications, most of them hasn't been approved in patients with IgA nephropathy and children. So I am going to let Dr. Shigan, who is a pediatric critical care senior registrar in South Africa, to present a challenging case of IgA nephropathy in one of his children.
Good evening, everyone. I just want to check, can everyone see my screen?
Yes, please. Go ahead.
Okay. So my name is Dr. Shagan Irison. I'm a pediatric nephrologist, and now I am doing critical care in the pediatric ICU. I'm associated with Stellenbosch University in our beautiful Cape Town, and I'm very happy to be representing the World Kidney Association for this, and thank you to our presentations. I'm going to do a case presentation that isn't that tricky, but does show the classical presentation of a child with IgA nephropathy. So before I do get there, I just want to tell everyone our upcoming IPNA conference is in Cape Town next year. It is between in February 19th to the 23rd. And hopefully all of you will come to see our beautiful, beautiful city if you haven't had a chance to visit before. And we also, as part of the World Kidney Academy, we do have our upcoming Pediatric Nephrology Fellowship that is starting in January of this year. Just to give everyone who is interested in pediatrics or pediatric nephrology, just to start on where we are with the niche of pediatric nephrology specifically. So our case summary. So I'm going to present a patient that presented to our renal unit in 2015. Whilst we know that IgA nephropathy is one of the most common glomerulopathies, in the renal units that I have worked in, I've actually not seen it that often. So this is an 8-year-old male patient presented with a nephrotic syndrome. with hypercholesterolemia and hyperalbuminemia, and had a 1-month history of intermittent macroscopic hematuria. And this was initially concealed from parents, and those that work with kids know that this is a common thing where kids are scared to tell their parents what's actually happening to them. And the child presented to us with a rising serum creatinine. A renal biopsy was performed by a nephrologist at the time. It was an adequate biopsy with 23 glomeruli, and did show moderate chronic inflammation fibrosis with a mesangial capillary pattern of inflammation. 12 of the glomeruli already showed crescentic changes, with 4 of them already evolving with fibrocellular changes. Immunofluorescence staining did show 2+ positive for IgA and 3C3 staining across the capillary wall. The clinical course, as per the protocols that we use in Cape Town, the patient was pulsed with methylprednisolone to try and induce and abort the inflammation. The patient received 6 doses of intravenous cyclophosphamide, which is what we have readily available, and diuretics with amiloride and Lasix were initiated to try and assist with edema. But the patient throughout the clinic visits, so over the preceding, the following 2 to 3 months, had persistent proteinuria that was ranging from 2 to 3+ positive on the urine dipsticks. And our clinical question was this ongoing active IgA nephropathy in the native kidneys, or was it chronic evolution of the fibrocellular changes, and was this patient an evolving CKD? So I'm just going to show you some of the results, and the first 4 columns are from 2015. And if we just focus on the first one of the initial presentation, the child presented with the creat of 127 with the urine protein creatinine ratio of 10.7 gram per gram. The next month, we did see some improvements in that, but following that in the next month, the patient's creat jumped back up to 116. And you can see throughout the whole course of this admission that whilst the proteinuria improved, the cholesterol remained elevated. And then after initiating further therapy in August of that year, the creatinine had fallen back to 57. And then at our last visit in 2018, the creatinine was still normal when we were last seeing this patient. So a repeat biopsy was done when the creatinine had jumped up. Now the 24 glomeruli, 4 with now global sclerosis. And of our segmental crescents, there was mostly of them were fibrous, but some of them were fibrocellular with chronic interstitial changes. And as we chatted about on the immuno, the C3 was still positive, the IgA was still positive, but when was this positive from? So we were managing this patient with an evolution of CKD1 with a GFR of 125 mils per body surface area. So the further progress, as I said, manages the CKD1 secondary to IgA. We initiated azathioprine, and I will touch on some of the drugs. I won't go into everything that we've just heard about. And we saw an improvement in creatinine and proteinuria in this patient. And this patient relapsed whenever azathioprine was weaned. And a concurrent ACE inhibitor, in this case enalapril, was started for the child and did initially show good response to therapy. The decision to change this patient to mycophenolate mofetil was done after 2 years. Unfortunately, the thiopurine methyltransferase was not measured, but the patient did have recurrent leukopenias. And with the change to MMF, we did see improvement in the leukopenias and ongoing decrease in proteinuria. So this patient, we followed up for 3 to 4 years in our clinic, but we have since transitioned to the private healthcare system. And we do know that the patient is doing well, but I do not have what the current medications are and where the most recent blood results are. So discussion, as I said, IgA nephropathy is the most frequent glomerular disease, and that ranges from 30 to 50%. And we see it quite commonly in our Japanese and Chinese populations. And it is defined with IgA dominant immune deposits that are present in the kidney. With the vasculitis, with IgA vasculitis being the most common form of vasculitis. And in our pediatric setting, we do see that in our emergency units, but very rarely do we actually find patients with IgA nephropathy. And we more commonly see post-infectious glomerulonephritis. So clinically, this can range from patients being asymptomatic to a glomerulopathy to, and in this case, a patient with a rapidly progressive crescentic glomerulopathy. And endocapillary hypercellularity and crescentic cellular crescents are generally very responsive to steroids and immunosuppressants. So this slide here I have taken from the KDIGO clinical practice management that was submitted for public comment for this year, that is available on their website. And if you just look at the very simple diagram on the right, which is taken directly from the guidelines, it is when you are considering an IgA dominant glomerulonephritis, do consider secondary causes in these patients. So viral causes, unfortunately, we do have a few children that are newly diagnosed HIV positive, inflammatory bowel disease, autoimmune disease, liver cirrhosis, and IgA dominant infections. And the goal of treatment, as we've heard before, is already limit proteinuria and therefore limit that progression to CKD. And primarily to prevent and reduce immune complex formation and deposition and kidney injury. So if you go down the algorithm, when you're looking at your kidney scores, there is something that is labeled a MEST-C score, which I won't go through all of it, but that's looking at mesangial hypercellularity, endocapillary depositions, sclerosis, tubular atrophy, and crescentic changes. And one needs to just quantify this risk and try and identify the patients that are going to progress to CKD. And as we've heard, there are lots of studies that are going on for some fantastic drugs, which unfortunately we don't have available, but if possible to register them on one of those drug trials. This year, I have got from a review paper there from Nature Nephrology in 2014, and just to show you the pictures of what we want. And I won't touch on all of that, but the first picture is just looking at the immunofluorescence that is lighting up with IgA deposition. You can see the mesangial deposits on B, and then I'm just going to skip all the way down to E, where you're seeing hypercellular mesangium with crescentic changes in that kidney, and then the patient that's now evolved onto segmental sclerosis. And the treatment, and this is a summary slide, which was done on our previous presentation. So managing the two different arms here, one look at IgA-specific drivers for nephron loss, and manage the generic changes. And I'll just start there. As you said, we have multiple new drugs that are available. And I will admit, in Cape Town and South Africa, we don't actually have the majority of those. Whilst we can control with angiotensin receptor blockers or ACE inhibitors, we do not, I'm not sure if we have the SGL2 inhibitors presently. And if we go over to the left, what we do have widely available is cyclophosphamide, azathioprine, mycophenolate mofetil, or CNIs. But drugs like Nefecon with targeted budesonide, we don't presently have. So often we do have our patients on systemic glucocorticoids and then initiate them on a steroid-sparing agent. And I think just to add on this, I've also reviewed a paper, not reviewed, but I went through a paper that was in the journal from the American Society of Nephrology that was published this year that does touch on a lot of those drugs. It was a review paper, which gives a very good overview of what drugs are available for these patients. And in that paper, they did mention, and maybe Prof, you can correct me, it mentioned that the current pricing of Nefecon is in the order of about $14,000 a month. I'm not sure if that has come down, but in our context, that is the limiting factor with our patients. And that's all I have for you. Thank you so much.
Very nice, very nice. Thank you so much, Jigan, for this challenging case. And also Africa, which might be very different from whatever Jonathan was mentioning in new studies. What do you think, first of all, Jonathan, about the price that was mentioned, you know, the Nefecon price that cost about $14,000 a month in Africa? Is this the same in Europe? I think this is, you know, a limiting factor in the developing countries.
Yeah, I couldn't agree more. And we make a real point of that in the KDIGO update. We have a section at the back, and we mention it under each of the new drugs that this is, you know, a drug that can be used, but is unaffordable in most of the countries where IgA nephropathy is actually a massive problem. And so even within the UK, we're having a discussion now. So in the UK, we have something called NICE, which is the National Institute for Clinical Healthcare Excellence, which agrees which drugs can be used within our health service. And they've approved Nefecon, but there are still parts of the country that are not using it because they're worried about the price. So our price is a lot cheaper than America, and it's confidential because they negotiate, but the price is a real issue. And just as an example, iptacopan has just been approved in the United States for the treatment of IgA nephropathy. Do you want to hazard a guess how much per year it costs in the United States? Just have a guess.
100,000.
$500,000 US a year. It is just ridiculous. There is no way I could ever justify spending that much money per year as a monotherapy, where the trial is going to look at it and you're going to say that's a lifelong treatment. That is just, that is ridiculous. So I think we are very cognizant that while I gave you that presentation and said at the end things are exciting, what I didn't do was put the next slide, which had a big currency sign in terms of the fact that actually there's probably only one country in the world that can afford it, and there's probably only 1% of that country that are going to get that drug. And that's the very, very sad world that we live in. One of the things I want to highlight is some fantastic work that's happening in India. So Sasina Alexander is a nephrologist in India, and what she's done, and I've been working with her, is she's running a countrywide study of 5 different interventions that are affordable in India, and if we show they work, could be instituted into clinical practice immediately. And so those are treatments that are mentioned in the KDIGO guideline, but there's not that much evidence. But if they work, they could translate into clinical practice immediately. So I think we need to be innovative about how we look at the drugs we do have available and how we can use them, like was mentioned in the South African case, using azathioprine, mycophenolates. We need to generate the data in a way that allows us to use affordable drugs better with more evidence, because that will really make a difference here and now.
The IgA nephropathy is not a life-threatening disease. It's not ANCA-associated vasculitis.
So I would argue the opposite. So if you look at the data, the data from Radar,
and also from our country,
John.
also, India also is quite bad.
Iptacopan, I just saw the study. It decreased the proteinuria 38%. Okay, that's good. That's good effect. But we have to weight the cost and the benefit. And
we do. I would much rather make sure every patient got an SGLT2 inhibitor than one person got an iptacopan. I just think it's obscene. And the big challenge we have is I've been going out convincing people to enroll patients in clinical trials. I get very uncomfortable if I've put a lot of effort into someone recruiting to clinical trials, and then all the risk they've taken, and then it generates a drug that no one can actually use in clinical practice. And lots of people are telling me in countries, particularly in South America and in Asia, why am I going to enroll patients in a clinical trial for a drug that I am never going to see in my country, or that I can see, but I can't afford for my patients? How can I justify putting my patients in a trial, exposing them to all the risk of an untested treatment, and then gain none of the benefit? But what we are seeing is some of the good clinical companies are actually saying, if you come into our trial as a phase 3, we will provide you with that drug for the rest of your life, or until it is available and it can be used in the country that you are in. So that is a real positive, and that's been due to the pressure of investigators saying, I don't know that I want to recruit in Argentina, or I want to recruit in the Philippines or in Sri Lanka, because you're never going to come, you're never going to get your drug approved here. When you do get it approved, it's going to be so expensive, I can't use it. So I think we are seeing the companies realizing they have a commitment, at least to the patients who put themselves forward for clinical trials. And that's a really positive thing.
Right. Let me just put one last comment before Professor Mujtaba have closing remarks here. Also, this new medication, we know what happened when the patient is on the medicine, but this is not lifelong therapy. So we don't know, until now, what will happen if they will be off this medicine after the 9 months of treatment or whatever. So I think we need longer term safety and efficacy data on these very expensive medications. Would you agree, John?
Absolutely. And we need to know whether they're safe to put together, whether we can combine these treatments, because we don't have that data either. And you're right, 2 years is a drop in the ocean for a 30-year-old who's got another 50 years to live. So we do need to also think about that. But what's great is I think we're where ANCA vasculitis and lupus were 30 years ago, when they started having treatments and they started saying, what's the best induction therapy? What's the best maintenance of remission approach? And they had the drugs to be able to test those out. We now have those drugs. And to be honest, I still don't think we know when to stop immunosuppression in ANCHOR. You know, even with all that research, we still have unanswered questions, and that's what's going to be the challenge for the next 30 years.
Thank you so much.
Yeah, do you want me to put together the closing remarks, Professor Amr? Okay.
Yes,
Good evening, everyone, and we've had a star-studded, team out here, led by Professor Barratt and Professor Ronco, and of course Professor Amr and Urmila. And then we had a wonderful presentation by Dr. Shagan to show us a little bit of the differences in presentation in a pediatric age group. But I think what we have learned over this entire fellowship that we've been part of as faculty or as fellows is that even during this fellowship, the whole paradigm has completely shifted from the era that we grew up in, where we were looking at things like, previously tonsillectomy in selected populations, or danazol or phenytoin, and then going on to things like, omega-3 fatty acids, and again, observational data, mostly not very good convincing evidence. And then we started going on to using steroid. We're looking at biopsying early with 500 milligrams proteinuria, with microhematuria being another marker that we're looking at. And then we started using steroids, and we said, well, this is not, so obviously along with all the ACE inhibitors and RAS blockade that we were looking at, we started looking at these sparsentan and atrasentan and these dual blockers. Then we started looking at MRAs like finerenone. But then somebody like Professor Barratt comes together and he says, hey guys, look, this disease has to be dealt with like an immunological condition as well as a chronic disease state. So you need to target the immunology of it, the galactose deficient IgA and all the immune complexes that form IgA and IgG, and then the pathway that goes on this side, which is activating complement, whether it is factor B, D, or the alternate pathway. But it's really the production which is important. So you have your gut dysbiogenesis, and you have your IgA production by the plasma cells using APRIL and BAFF. So we need to be targeting APRIL and BAFF rather than simply using our ACE inhibitors and blood pressure control and smoking cessation and all those good things. So all of these things need to come together. It is a model where these things need to be done in parallel. And we've been doing a disservice to our patients in the past by condemning patients to IgA nephropathy, to dialysis or transplantation within 20, 30 years, because a lot of them present early, and we need to hit all these targets early. So with atacicept and revoluzumab and all these other wonderful drugs that I can hardly pronounce, so felzartamab and all that. So you have all the targets that you're getting, but the problem is that you have a worldwide diversity of population, you have genetic polymorphisms. You already knew that in the Chinese population, maybe mycophenolate worked, steroid worked in somebody else, and maybe tonsillectomy in the Japanese. But now we need to have more than just the biopsy and the IgA nephropathy prediction tool. We need to have targeted therapy using patient values and preferences, and of course, cost effectiveness as it is, as I think will drive how we are going to be looking at this as a disease. But I think it was a wonderful discussion. Lots of questions came in related to some of these aspects. I think some of them already been answered. The rest were also some things that I kind of just alluded to briefly in my small summing up. It's a big task for me to do so for giants in the field, but this is the best I can do as a practicing clinician in a developing country. Thank you so much for giving me the opportunity, Professor.
Thank you so much, Professor Mujtaba. Thanks you so much, Professor Barratt and Professor Ronco and Professor Anandh. Thank you, Dr. Shagan. And hopefully we'll see you in our monthly GN webinars in the future.
Thank you so much.
Thank you. It's been a pleasure. Thank you. Bye-bye.
Yeah, thank you.
Bye-bye, everyone. It was a pleasure for me too. Bye-bye.